is Practical Tips for Healthcare Transition, and honored to welcome Dr. Jordan Kemere, who's an assistant professor with Baylor College of Medicine Transition Medicine Clinic. If you can reference the attendee website, you will see the full bio listed there. On the next slide, you'll see her the CEU accreditation and disclosure statements, as well as you can see these on the CEU tab in the attendee website. We also have the learning objectives for her talk listed here as well. With that, I'm going to invite Dr. Kemere to take the reins and share her screen. Thank you.
All right. Good afternoon, everybody. I am so happy to be here and excited and honored to be invited to talk with you guys. This might be a little bit of a change of pace. We're going to try to get really practical today. And I hope that this talk is going to be something that everybody in the audience can take away, whether you're a parent, a patient, a social worker, a case manager, a physician, any role that you play. I think that you're going to find something that you can take away from today and use moving forward. So first, I think it's important to just kind of define what I mean by healthcare transition. So this is really a process, and hopefully a planned process. A lot of people think about transition as, oh, this is the first time I went to the adult doctor, and that is transition. Transition really is something that ideally takes a number of years, and it's really the planned process for adolescents and young adults to move from a pediatric to an adult healthcare. And this doesn't only mean doctors, but also talks about kind of how the framework shifts, how people think about medicine. It also implies hospitals, facilities, DME companies, nursing agencies. And so it can be a pretty complicated process. Some objectives that I'm going to try to hit on today are talk about some barriers to successful transition, recognize opportunities to talk and think about transition early and often, both from a genetics provider standpoint and also from a patient or family perspective. And then think a little bit about what is helpful for adult primary care providers as they're receiving patients with genetic conditions. So first, who I am, I think it's probably important for you guys to understand my perspective. So I'm an internist, and I am a primary care doctor at a clinic in Houston at Baylor. It's a patient-centered medical home for adults that have intellectual and developmental disabilities. It is a beautiful place to work. We have social work in-house. We have case management services. I think not only about patients transitioning from a physician perspective, but also sort of what adult life looks like for a lot of our patients. And we have probably 1,300 patients at this point, and these are some of the more common diagnoses that we see in our clinic. This is a great picture of some of my patients that participated in a peer mentorship program with me. And I have learned everything basically from families and patients and talking with a lot of my pediatric colleagues. And I understand that where I work is a little bit of a dream scenario, and that not everybody has the support that I have. But I think we can all kind of move from where we are and improve in terms of transition. So first, I think everyone can make a goal. So as I said before, we have a pretty diverse audience here today. I listed some possibilities just from a doctor perspective who might be on the call. And so thinking about who you are, we have some pediatric geneticists that may actually be only seeing a patient a few times, providing a diagnosis, and then handing back off to a pediatrician. We have pediatric geneticists that may hand to an adult geneticist and also to an adult PCP. We may have a metabolic geneticist on the call, for example, that might continue to see a patient for the rest of their life, but may now have to partner with an adult primary care doctor. And then we may have an adult geneticist who happens upon a patient and then wants to establish them with primary care. In addition to all of this, we also have social workers who are going to interact with patients. We have genetic counselors and counseling students that are going to interact with patients. And then we have patients and family members on the call. And so I think no matter who you are, you can play a part in transition. And so I want you guys to think about this 30 minutes, like very practically. I want you to say, during this talk, I'm going to pick one practice change that I'm going to make going forward. And it doesn't have to be a huge thing. It can be a small thing that's going to either improve healthcare transition for the patients that I interact with, or maybe for myself as a patient or for my child. And so I'm going to throw a lot of practical tips at you guys, and I want everyone to try to think about one thing they want to do differently going forward. So first, before we jump in, what's some data on transition? So I would say in terms of the literature, we're really still in an assessment phase at this point. A lot of the literature that's available within looking at transition in the patient population with genetic conditions comes out of Europe right now. I think they have great registries. They have the ability to look at large numbers of patients based on their healthcare systems. And a lot of it is still in the assessment phase. So we don't have a lot of great data on what are key interventions that lead to successful transition, though I think a lot of those papers are slowly starting to come. But what we know from sort of the assessment phase, I think won't surprise you. So just as an example, this was from a genetics work group and looked at children and adults with genetic conditions, and they did a big survey. And they either surveyed patients or their parents, and just looking at only at questions they asked about transition. This is in respondents that are teens. A lot of them saw doctors that only treated children. And so at some point they would have to transition. But a very small number of those people had ever talked to their doctor about who they might see in the future, or that they would ever need to see a doctor as an adult that was different than the pediatrician or the pediatric geneticist they were seeing. So I think at a baseline, it's not something that's talked about really frequently. And so if we're not even kind of starting to think about it, then it's hard to sort of move forward and make change. What are some of the barriers? So we actually surveyed, I worked closely on a project for a while with our metabolic genetic clinic at Texas Children's, and we surveyed the providers in that clinic. And we surveyed some providers on the adult side. And I think a lot of you guys that are providers could come up with these barriers pretty quickly. So time is a big one, right? There's a lot to do in these visits. And I think transition is often something that can get put on the back burner. Oh, we'll just talk about that at the next visit or the next visit. Some people are in a situation where there's not a lot of social work or case management support. And so if a family does bring up an issue, a provider may not know where to turn, what resource to provide, and may not have someone that can step in and research that and provide those resources. I think some of you may feel this more than others, but I think sometimes there's some unclear roles. And so thinking about who's doing what. Some geneticists wind up sort of being de facto primary care providers for some of their patients. They develop these beautiful relationships. They're managing exacerbations of their condition. And so I think sometimes the pediatricians or the PCPs sort of take a back seat, and nobody really knows, is anybody talking about transition? And if yes, what are they addressing versus what should I be addressing? And then I think on the receiver side, as someone who trained in internal medicine and frankly got very little training on both genetic conditions and adults with IDD, there's a lot of fear. There's definitely some lack of knowledge, but there's a lot of fear. And I think this instant reaction on the adult side that I don't know anything about that condition, I might hurt someone, I don't think I can do this. And then I think insurance changes, particularly for those who are eligible for Medicaid. There are dietary supplements, there are formulas, there are medicines, there are nursing hours, there are all kinds of things that are no longer covered once people reach adulthood and maybe change over to adult insurance plans. And these can also be some big barriers. And I know that a lot of you have run into those barriers. So what's kind of, with all that in mind, I want to provide sort of a framework for, even though I don't think we have great data right now about interventions, Got Transition is a great website that I think is sort of best practices in terms of thinking about transition. And so if you're not familiar with this website, whether you're a doctor or a family member or a patient, I think it's reasonable to take a look at this website. And they provide some different things you want to be thinking about as you're walking through this period of transition with some ages. And these are sort of arbitrary, but there's some nice guidelines. These, I think, are more well suited in a primary care practice, but we've adapted them and used them in some of our genetics clinics here. And then they also have parent and patient websites or sort of offshoots of their website where they provide a lot of good materials for thinking about it from the patient or parent perspective. And so I think all that being said, now going forward, I want to give you just some practical tips that we've used that I think work really well. And I'm sort of going to alternate between addressing more of the provider side and then addressing more of the patient family side. One, because we have a diverse audience. And then two, I think it's helpful even as a provider to know what our patients and families thinking about, and when they come to your office, kind of what are they working on and what are they thinking about. And then again, when I give you these tips, I want you to think about what your goal is. Remember, I said at the beginning, we were going to all try to come up with a practice change that we were going to make. And then two, I want you to think about how you could use your whole team. So transition really can't fall on one person. And so you want to think, okay, I've got an MA, I've got a nurse, I've got a medical student, I don't know, I've got a genetic counselor, I've got a social worker. Maybe you have a few of those pieces. And so you want to think about how can everybody on my team play a role in transition, because many of these things don't need to be done only by physicians or only by social workers, and different people can play different roles. Okay, so first, in thinking about early adolescence, I think from the provider perspective, this is a good time to actually provide a written transition policy. So no one likes to be surprised, and there's nothing that sort of makes handoffs and transitions worse than showing up for a doctor's visit and then someone saying, this is the last time that you're going to see me. Next visit needs to be with someone else. And so you actually want to provide this policy to your patients. And it may be that we stop seeing people at 18, we stop seeing people at 21, or it may be that we'll continue to see you as a genetics patient the rest of your life, but letting people know that in advance, I think, is really important. And so that's one tip. The next is, I think it's a really good time to sort of revisit the basics of the genetic conditions and the inheritance patterns. So we surveyed patients and caregivers in the metabolic clinic, and less than half of the people, both in patients and parents, felt like they had a good understanding of what their condition was, and even fewer knew what the inheritance pattern was for their condition. And so a lot of people got this information maybe from newborn screening, or maybe they had genetic testing early on and they got their diagnosis, but there was a lot of information coming at them at that point, and they don't always remember it. And then a lot of patients, some of whom may be capable of understanding and discussing and talking about their condition, have never had someone provide that information directly to them. So this is a great time to also add that in as part of your visit in a genetics clinic. I also think it's a great time to start exploring self-management and meeting with adolescents by themselves. I have patients that have genetic conditions that have moderate intellectual disabilities. So maybe have, kindergarten, first grade, maybe 4-year-old level of understanding communication functional skills. And even for those people, I often kick their parents out and talk to them a little bit about how they're feeling, how they're doing. And I think that it's great to kind of see what people can do with that. Sometimes I'm really surprised at the conversations I have when I'm by myself with them. And so I think just like you would do that for an adolescent patient who does not have an intellectual disability or genetic condition, you should also be doing that for these patients. So from the parent-patient perspective, again, it's more than just making an adult doctor's appointment. So self-management skills that we just talked about. Now is the time to sort of explore what your young teen and teen is able to take on. So if it's medications, if it's a dietary plan, if it's formulas, some people can do it all. Some people need full support, and a lot of people are somewhere in between. So you want to actually start practicing their care plan with them before they're 18 and they're headed off to college, or before they're expected to do everything all by themselves. And so I actually tell parents and patients, pick one thing that you want to start working on. Is it that they're starting to take their medicines more independently? Is it that you teach them how to make their own doctor's appointment? Is it that you teach them what number to call for an emergency, and you work on it and you do it in a slow pace and in a way that's safe and that has some backup? And yes, people are going to make mistakes, because I even make mistakes when taking my own medicine, right? But this is a safe time to start practicing that. The next thing that I tell people is it's a good time to get organized and make something called a medical summary or a care plan. So I tell patients and parents that these ages, sit down with your child. And if they're able to participate, you guys sit down together and you make a 1 or 2 page medical summary. This is going to list what are your main medical conditions, what doctors do you see for those conditions, what is the treatment plan for those conditions, and then also we'll include who all is on your healthcare team. And by that, I mean, other than doctors, is there a social worker you interact with? Is there a genetic counselor you interact with? Are there medical equipment companies that you use? Is there a nursing company you use? And you sort of organize that information. And then you take it with you and you take it to your primary doctor, you take it to your geneticist, you take it to your pulmonologist, and you ask them, can you look at this with me? Does this look accurate? Is it too much information? Is it not enough information? Because this document becomes very valuable when you actually move and you see new adult doctors. And it also is just valuable when you go to the ER, when you're on vacation and something crazy happens and you say, my child has OTC. And the ER doctor gets these huge eyes like, and then you say, don't worry, I've got their whole care plan right here. Okay. And then the last thing I'll put out there is Medicaid waivers. And I'm not going to go into this, but if you are working with patients that have genetic conditions, or you are a parent or a patient, you want to Google the name of your state and Medicaid waivers, and you want to understand them, and you want to understand who's eligible. In Texas, for example, these waiver programs provide funding for wraparound services that Medicaid does not cover for adults, but most of my patients are on a waiting list for 15 years before they come up for these. So if you don't know what a Medicaid waiver is, your homework is to Google, your state Medicaid waiver and learn about what the programs are. And you want to make your patients aware of these programs, and you want to get them to sign up on the waiting list the second they get their diagnosis, whether that's when they're a newborn or they're 2 or they're 5 or they're 7. For patients who have disability and are not going to be able to work full-time as adults, this can be really, really important. Okay, so back over to the provider side. So thinking about as we're getting into later adolescence, again, I think from the provider side, we can encourage self-management and safety. And so we actually did a really fun QI project, again, in response to our survey, where a lot of people didn't know who they were supposed to call in an emergency or how to make a doctor's appointment on the pediatric genetic side. And we had medical students go into every room with a QR code and then a little laminated card, and basically help people put into their phones the clinic number and then the on-call emergency number. And we would do that for both patients and their parents. And so that was a really fun QI project that our medical students participated in, that was easy and I think really made a change. A different project where we were making sure everybody had emergency letters if that was appropriate for their condition. Another thing you want to do is if you have social work support in your clinic and you're lucky enough to have that, you want to use it. And we actually recommend that social workers start meeting with individuals in their teens, and they meet with them once a year, whether there's anything important to address or not. It's much better to get in there, get to know people, try to provide some guidance, and not just be putting out fires from a social work perspective. And there's so many things to talk about. There's insurance changes, there's decision-making supports that may or may not be necessary. There's education and job planning, there's adult disability determination, the list goes on and on. And then I think you want to start helping your patients identify adult partners, whether that's an adult geneticist or an adult primary care doctor. This is the time where you want to think about, okay, where do they live? What's appropriate for them? What do they need? And start trying to identify those things for patients. From a patient or parent perspective, I think this is a time when, for some people whose children may have intellectual disability, you're really starting to think about consent and guardianship. Age 18 is that time when people can make their own decisions and they're considered an adult and independent, from their parents. And so these are things you want to be thinking about and talking to your doctor about. It's also when Social Security determination comes up. So parent income is no longer counted at age 18. And so for some people who are disabled, this is when they can receive Medicaid and also receive Social Security income or SSI. And then again, for some people, they'll start transferring to adult providers around this time. Some people, it may be a few years later, but you really want to start thinking about who those people are going to be. Okay, now we're kind of getting into where we're actually sort of moving over to the adult side. And so I think as your patients are moving, before they move, you really want to try to solidify a care plan for them from a genetics perspective. And so I think it's worth writing it down. I actually use the problem list in Epic for this, especially if they have a couple of problems that I want to address. And from a provider perspective, I think it's nice to be able to say, okay, this is the treatment, and this is maybe there's certain screening for that particular genetic condition that might be different than the regular adult screening guidelines. And so you want to actually write that down. And then also just recommended follow-up. And so this is a good time to really solidify that care plan with the families and make sure that everyone's on the same page. Another thing that we do that we love is we work on fact sheets. And so this was a project that some of our residents did. And there are fact sheets online for different disorders. And so you can find one online if you like it. This is a great thing to give a family, especially if they're leaving your pediatric clinic, or even if they're just going to meet a new doctor. And we try to come up basically with a one-page sheet that says, for example, this is OTC, this is the disorder overview, this is the typical treatment, this is things to watch out for in exacerbation, this is things to avoid in terms of other medicines that might cause an exacerbation, and then here's the name or the number of their metabolic geneticist or who to call in an emergency. And so we've utilized ones that we found online. We have created our own, which we did in the case of OTC because we really wanted to do our own for this one. And I think these are really handy. And I have seen adult doctors just relax when they actually meet a patient with a condition and then they're given a fact sheet. And it's just sort of like, okay, this is some information. Yes, you can look stuff up on UpToDate, but just having that physical paper that is simple and one page and is really coming from the geneticist that knows them, I think makes a really big difference. So this is a fun project for learners as well. And I think really can help adult doctors sort of ease their fears and give them some guidance. And then finally, I think don't be afraid to get to know one or two people on the adult side or on the pediatric side. And that may require a few phone calls or just getting to know them, but it makes transition so much smoother. And it also, I think, can save you time down the road, either if you're someone handing someone off or if you're receiving. Okay. From the patient or parent perspective, you're thinking about transfer of a lot of things, not just doctors. So insurance continues to change. Maybe your child got eligible for Medicaid at 18 through Social Security determination. When they turn 21, that's going to flip from a pediatric to an adult Medicaid. And so a lot of stuff is moving parts in here. You're thinking about, okay, maybe your child is more medically complicated. When you switch to adult Medicaid, nursing hours often drop dramatically. Dental care changes and is not reimbursed very well from an adult Medicaid perspective. So there's a lot of moving parts for parents in these ages, and it's really, really stressful. They're also losing sometimes the care team that they know and love, and sometimes they're even losing that children's hospital that they know and love if they've been there many, many times. And so I think there's a lot of stress at this age. And then they're also, as a parent, you're also thinking about maybe education and what that's going to look like going forward versus employment or volunteering or day programming. And so these are all things that the earlier you think about them and you address them, the better off you are. The last thing you want is to kind of be reactive. And in terms of all these things, you want to be proactive as you can be. Okay, and then post-transfer. So I think in terms from the geneticist or the provider perspective, it's okay to call your counterpart, either the person that you received the patient from or the person, or if you gave the patient to someone, and just ask how it went and get some feedback. We do this, and sometimes, and we learn more, I think, in that quick post-transfer phone call or email than maybe through a lot of other processes. So I think this is really best practice, and it can be hard to do. But I think you'll learn a lot about what went well and what didn't go well, and it'll help you for the future. And then I think this is a question for everyone to think about. So I get a lot of patients with rare genetic conditions, and maybe some more common ones that were followed pretty regularly on the pediatric side in a genetic clinic. Granted, I'm in Houston, right? So TCH is across the street, and there's a million different awesome genetic clinics at TCH. A lot of my patients ask me, do I keep going every year to see that particular geneticist? If they do transfer to an adult geneticist, the adult geneticist often says, how often should I see this patient? And so I think it's interesting to think about how often will you see an adult patient that maybe has a known and stably managed genetic condition. And I think you want to communicate that not only to the patient and their family, but also to the other providers in the care team. And so it may be, okay, if everything is going great, I want to see this patient every 3 to 5 years so that I can review the literature, see if there's new screening guidelines, see if anything new has come up, see if there are new therapies coming down the pipe. And that certainly has been true. I can think of a few patients that I've referred back to genetics because there was a new trial being offered, a new therapy being offered. And so I think it's interesting for you guys as geneticists to sort of think of it as a group, as what is the frequency that we want to see these people at, and for what purpose. And I think parents a lot of times also want to know what the answer to that question is. And then from a family perspective, insurance actually keeps changing. So people who have who are considered disabled are allowed to stay on their parents' private insurance even past the age of 26. And so that's a whole nother time when insurance may or may not change again. And then a lot of my patients become eligible for Medicare as they age, and their parents become eligible for Medicare if they are adult disabled dependents. So things keep moving. And then I think even after 21, I think you kind of make it through all of this mess and all these hurdles. And then a lot of families are really starting to think about long-term planning. And if your child is dependent, then what would happen if I couldn't take care of them anymore, right? What would happen as a parent if something happened to me, and where would they go and what would they do? And I will say that every situation is very different, and that people often have to try many different things. Okay, they're going to live with me. They're going to live in a group home. They're going to live in a supported environment. And so sometimes it takes lots of different options and to try different things to figure out what works. But as a patient, and as a parent, there's still a lot of moving parts and a lot of transitions that keep happening as you age. And then I think lastly, to stay informed. So I have some patients who are in their 40s, and their parents are still, they're in their 60s, 70s, and they're still attending conferences. They're still going to parent support groups. And I think most of them would say that it's lifelong learning, and that there's something beautiful about being able to mentor younger families. And then there's also something that they're always learning. And so I know if you're listening to this conference and you're a patient or you're a parent, you already are part of a culture of staying informed and being involved. And I think this is something that you'll want to continue as part of your lifelong journey. So finally, just some tips. And so, to kind of overview what we've talked about, it's a process, and you really can never start too early thinking about these things, whether it's signing up on a Medicaid waiver list, thinking about self-management with your child and what that's going to look like. And let's say your kid is 17 and you've never thought about any of this. Well, you just start where you are. You're not behind. You just need to start where you are. And then I think from a healthcare provider perspective is utilizing your whole team and your staff. What can all these different members of your team do? And how can they help with transition? And then you want to set really small and achievable goals. You want to pick one thing and work on it. Do that and pick another thing and work on it. I told you guys something as simple as a QI project and making sure that everybody has the after hours number to the clinic, or how do you make an appointment in this clinic? And it's small, but that's how you're going to move the needle, and that's how you're going to make change. And then finally, I think really just to make friends with primary care doctors and your pediatric and adult genetic counterparts. Some of my most lovely patients are people that I had never heard of their disorder until I met them. And I have been enriched as a doctor by learning about different things, and I have learned so much from their story. So I think there are a lot of adult doctors that with enough, with a fact sheet and a phone call would do this work and would really be enriched by it and learn a lot from it. But I think it's our job to make friends and to get people onto our side, and show them how much we love what we do. Finally, this is my email. Please email me if you have any kind of questions about any of this material. I also educate a huge number of learners, from social workers, students to nursing students, PA students, medical students, residents. We even have a fellow in my clinic now. So I really love also educating people about transition and about adults with IDD. And then a quick thank you to all of my colleagues in my clinic at TC and at TCH, especially Lindsay Burridge, who's a great metabolic geneticist and really, I think, partnered with me in thinking about transition in the genetics clinics at TCH. And then finally, I just put a couple of references. So if you're a family member of the ARC or the National Disability Rights Network are two things that you should become familiar with. And then the Got Transition site, which is gottransition.org. All right, and with that, I'm going to stop sharing, and I would love questions. I love talking about this stuff, and there's, ask me anything you want.
Thank you so much, Dr. Kemere. We have some questions already coming in. So are you ready?
Oh, yeah, totally.
For a couple of them? Okay. Top question here is, do you have a template or a suggested resource for drafting a written transition policy?
Yes, I do. I think that there may be some on Got Transition. And if there's not, then I am happy to email anybody who sends me an email. And I can email you some different options.
Perfect.
Which is my last name at bcm.edu.
Perfect. And those slides, just so everybody knows, can be found on the attendee website. You can download her slides as a PDF, which has her email in that. All right, we have another question here. What efforts can be made to help children transition to adult care who have a lifetime issue and that have never been properly identified or resolved? How many children reach adulthood in that position?
Yeah. I think the diagnostic odyssey is really hard. I think that, so I saw a patient yesterday who has never received a diagnosis and is now at the point where they have so much sort of combative behavior that they can't have blood draws. They can't really, it's hard for me even to do an exam, and they're 25. I would say I see it not infrequently. And a lot of times I think what has happened for patients in their 20s and 30s is maybe they got some initial genetic testing 20 to 30 years ago, and then they didn't really, sometimes they didn't get answers. Sometimes they didn't have a good experience just talking with people about the condition. And a lot of them maybe haven't been reapproached and say, hey, maybe we could figure out a way to get a whole exome sequence done for you. Or maybe there's some newer genetic tests that would help you. Or they have been approached and the prior experience was so unsatisfying that they don't want to go through it again. So I think it's more common than I ever realized, first of all. And then, so sometimes I will, the way that I sometimes move the needle and am able to get people to reconsider genetic testing as an adult is when people have siblings that maybe want to have children. So that's one thing. I say, hey, we don't fully understand this. It may have nothing to do, may not be heritable in any way, but it might be. It could be spontaneous or could not be. And so I often will talk a little bit about do you have a family member? Do you have a sibling? Like sometimes they might want to know. It might be important to them before they have a child to better understand the risk and what's going on. Other times I've been able to give people examples of how knowing someone's condition allowed me to kind of understand better what to screen them for as an adult. On one level, I know how to take care of adults. They come in, we do blood work that's indicated either by their age or their comorbidities or what medicines they're on. But I do have some patients that I'm going to do different screening or look at different things because I know their diagnosis. And I think even when I present all of that, there's a small subset of people that aren't interested. There's another subset of people that are interested and get an answer. And then there's another subset of people that are interested and they still don't get an answer, even after they go through all of that. And I think it's a hard place to be. But then I remind families that at this point, we're talking about function and quality of life. And so sometimes we don't know, and we're not going to know, at least not right now. Maybe something new is going to come out and we're going to know later. But then we try to function on, or we try to focus on, okay, what makes our life good? How can we optimize for that? And how can we improve function or maintain function as best we can? So if you're at that place where you don't know, you're definitely not alone. And it's really, really hard.
Thank you for that. Thank you for your empathy too, because we hear from a lot of families in that situation. So we have another one here from an adult provider saying, as an adult provider, I found having parents along for the youth's first visit or so assist with the transfer process for youth and family. We encourage other adults to bring in their support person, spouse, sibling, adult child to visits. What are your thoughts?
Oh, totally. I tell people I like to meet with people by themselves for part of their visit, but I think it's great to have a support person. I actually don't have serious doctor's visits by myself. I mean, I don't, my mom and dad don't. And because sometimes if you're meeting a new person or you have a lot of questions, I can't remember everything I wanted to ask. I'm nervous, I'm worried. And so I think having a supporter is really important. I think from a provider perspective, you have got to focus your questions and your attention on your patient, and that will allow them the freedom to respond directly to you. In the beginning, they may be looking at their mom or dad the whole time, like, are you going to answer? Am I going to answer? And I think I just keep looking at my patient and talking to them. And then if they don't know and the mom answers, that's awesome, because that happens and that's okay. But I think it's great to have people come with them. And then I try to be mindful that I'm going to kick them out at some point. And maybe we get to a point where we all know each other well, conditions going well, everything's stable, and they can come by themselves. But I think it's totally fine to have people come with them, with the caveat of you want to avoid the temptation to shift to parent and just do the visit like this. And then you also want to make sure you give some space, if not at every visit, at some visits, to talk to the individual by themselves in case there's something private they want to share.
Great advice. And then this next question says, you mentioned referring back patients for new therapies. Are you screening your patients' files for those matches in between seeing them? Say previously you said 3 to 5 years.
Ooh, hard. Okay, so okay, no, we do not have a great system. I'm just being honest. We have been hit by this because there's been some cool new therapies, right? And so I have a patient with Morquillo, okay? And a few years ago, I was just seeing my patient. She was cruising, and we got a new attending who said to me, isn't there a trial at TCH for Morquillo for a therapy? And I was like, there is? And I was mortified, right? Because I've been sitting here, and so I think I don't know the answer to that question. I think just like the rest of you guys, sometimes I feel too busy, right? And it's hard for me to look and say, okay, tomorrow I've got 15 people I'm going to see, and I've got 5 genetic conditions that I don't read about all the time. And am I realistically going to be able to review the literature every time? So I don't know what the answer is. And I don't know, as a primary care doctor, I think I need to be doing some of it. I don't know that I can do all of it. And then I don't know, as an adult geneticist, or maybe as a pediatric geneticist that still follows adults, where you guys land on that. Do you say, because sometimes parents say to me, I go every 6 months to this genetics clinic and they never do anything. So I try to explain, okay, but they're looking at the literature, they're thinking about this, they're thinking about that. So I don't know what the answer is for a 30-year-old who is like, do I still have to go every 6 months? I don't know. I don't know if that's patient-centered. It's hard. So I think it's just a good conversation topic.
I was just going to say, it sounds like a great conversation that maybe Mountain States could facilitate in the future, having a roundtable about that. All right, we have another one here. We had an earlier talk about telemedicine. How do you envision how telemedicine might play a role in improving the transition to adult care?
Oh,
totally. Have you seen that happen during COVID, perhaps?
Yeah, absolutely. So I think, yes, and there are. Okay, so on the Got Transition website, there's also some initiatives for things that you can bill for in transition. You can bill for them. Whether or not insurance pays for them is a different story, but we're all hoping that insurance will pay for more things related to transition. Telehealth is wonderful in the sense that when the pandemic started, we actually, for our really complex patients at TCH, they didn't necessarily want to have a super long visit even before the pandemic, and like meet the doctor and then talk to the social worker and then do all this stuff. So some of the social work and the care planning aspect actually got done on telemedicine. And I think some of the care planning stuff and the social work doesn't need to be in person and can be done on telemedicine, and then also can be done by case managers. We have a nurse practitioner who's worked on it. I think this is a great place for a lot of the transition efforts to happen, because it is also hard to get someone to come back to your giant medical center or to your office or wherever you are solely to talk about transition, but they would get on a televisit for 30 minutes and talk about it. Going forward, we're trying to do more in transition at TCH, and we actually envision that a lot of it is going to be via telemedicine. So I think that's a beautiful point.
Perfect. Perfect. Well, we were almost out of time, so I'm just going to ask you one more. This is about resources in other languages to give families. Do you have any resources that maybe you could pass along to us that we could post when we post this on our website, especially for non-English speaking family members?
That's great. First, I'm going to share and show you guys, this is the sample policy guide. There's a sample letter on GOT transition for like that policy that I think someone asked me about. And I can also share some of the ones from our clinic if you want to email me who asked me that question. And then I think, is there stuff? I'm trying to remember if GOT transition has, they do. Okay, so they have most of their stuff is also in English and Spanish, which is limited, but I think at least in our mountain region, that's one of our more common languages that are spoken. And so this particular questionnaire that's in English for parents and caregivers questions to ask your child doctors, they have a lot of the parent and patient resources are in English and in Spanish on GOT transition, which is great. That's my first instinct. And then there is a woman who does a lot in our community with Spanish speakers who's fantastic. And I can also reach out to her and ask her what other resources she gives families too.
Perfect. Thank you for sharing that.